All right, good morning and welcome everyone. Thank you for joining us today for our first of many Making the Connection Conversations Around Integrated Care offering. My name is Meg Buyer. I am part of the Managed Care Technical Assistance Center team, and I am a member of one of the teams of individuals who've been working on this offering. As you can see listed on this side, we have many partners who have been working together to pull this offering together, from CPI, New York City DOHMH, New York State OAHMH, and New York State OASAS. And I want to thank all of our partners who've contributed to our offering and making this happen today. We're going to get started, and I'm going to ask my colleague to advance to the next slide, and I'll run through some logistics for things today. So as I shared, we're going to be having a very exciting presentation by our partner shortly. A few things, though, about the logistics for today. This webinar is the first of a series of 6, and maybe even more than that in the future, depending on how this goes. So the purpose really is to support our providers, our New York City-based providers, clinic-based providers, and really working through, issues that folks might be encountering around the integration of behavioral health. And what I mean about behavioral health is mental health and substance use disorder, the better integration of those two factors. The purpose really is to give providers the opportunity to share a case that they might be having some issues with or struggling with or looking for support around. As you may have seen from the announcement, we are asking our providers to submit cases to MCTAC. MCTAC is going to review these cases, select a few, and also select corresponding subject matter experts that would work with MCTAC to look at the case, provide some solutions, recommendations, and ideas, and then would also work with have a one-on-one consultation with the provider that submitted the case. Ultimately, this case would be presented at a future MCTAC webinar. And we understand, there's anxiety sometimes about submitting cases, and especially submitting cases that people might be encountering difficulty with. But what we're really hoping here is that the opportunity to work with a subject matter expert and MCTAC will support the providers who submit these cases and ultimately finding solutions as we move forward. So that's the general format of our webinar series. I do want to just be transparent and say that today's webinar is slightly different in its focus. Today, we're not reviewing a specific case. Today, we're actually going to, our partner will walk us through assessing substance use for our presentation today. So moving forward, though, our hope is to really have some cases that we can walk through on each of these monthly webinars. So I'll pause there for a moment. That's kind of the purpose and overview of the series. Other details for today are as we do for our MCTAC offerings, we are going to have an opportunity for question and answer. And just slightly different for those of you who might have joined for some MCTAC offerings in the past, while we do encourage you to submit your questions throughout the entirety of the presentation, we are saving time at the end of the presentation to address these questions. We would encourage you, again, just to not save all your questions until the end, but to chat them in throughout the entirety of the presentation. I know sometimes when I'm engaged in presentations and webinars, if I don't send in the question, when it pops into my brain, I probably won't remember it at the end. So we encourage you to share your questions throughout the entirety of the presentation. MCTAC is collecting them all, and we'll be able to review them at the end of the presentation. The other thing I wanted to say about Q&A is that we are, at the end, when we'll be addressing the questions that are chatted in using the chat box functionality, we'll also be asking folks if they want to ask a question directly. So if you, at the end of the question, raise your hand, we will be able to unmute you and you could ask your question live. So there's 2 options for question and answer. You can either chat your question in, or you could raise your hand and we could unmute you at the end of the presentation. And so with that, the last thing I'll say is before we end today, we will be chatting out a satisfaction survey to everyone who's joined us. And we ask that you take 3 to 5 minutes to fill it out and give us your feedback, because this those satisfaction questions are really helping to drive how we deliver these webinars as we move forward throughout the series. So with that, I want to thank you all for joining us today. And I want to pass it along to my partner from OMH, Kelly, who is going to frame the purpose again of the webinar today in the series and how we got to delivering this webinar.
Hi, everyone. Good morning. I was just scrolling through the participant list, and I think I've spoken to a lot of you before, but my name is Kelly Bevins, and I work at OMH, and I'm our integrated care point person. And so I'm sure many of you know integrated approaches to providing mental health and substance use services is shown to improve treatment outcomes and reduce the costs of care. So with that in mind, OMH, OASAS, and DOHMH came together, and we wanted to develop a resource for providers to ensure that they have access to clinical consultation and guidance for the treatment of individuals with both mental health conditions and substance use disorders. So we sent a survey to all the New York City Article 31 clinic providers back in July. We wanted to get a better understanding of how you currently provide integrated care, what barriers exist, and what supports would be helpful. And we actually spoke to some of you on the phone as well. And so based on that information and then that interagency work group, we partnered with MCTAC and CPI to develop this series. And so we are piloting this collaborative with New York City clinic providers over the next 6 months, and we hope that it is successful and helpful and we can expand it to the rest of the state. Just to give you an idea of what to expect for each session, a panelist will review, and Meg did talk about this a little bit, but I'm going to reiterate a few things. A panelist will review a case submitted by a provider, facilitate a discussion on approaches to providing integrated behavioral health care treatment, and then provide some additional education and guidance. Each session will highlight key topic areas, for example, like substance use 101, motivational interviewing, that type of thing. We are very excited to offer this resource to providers, and we hope that you find it useful. Like Meg mentioned, today's format is a little bit different than we originally envisioned, just because we really haven't received any case submissions yet. And we just sent out the link only a month or so before today's meeting. But I would really love to encourage everyone, if you can, or if there's a case that sticks out to you as we're going through today's presentation, I'd really like to encourage you to submit it. And if you're willing to share, some of the benefits are that you'll get additional one-on-one support and guidance from an expert. The other piece is it can be completely anonymous. So MCTAC will receive your submission, but you can select to either present the case or be involved in the presentation of the case or not involved. You can request that your information or your agency's information is anonymous. So OMH and OASAS would not receive that. So I just want to let you know, it really is, something that we're encouraging providers to do so we can help others and help providers and offer that one-on-one assistance. So I think we've made a good plug now, Meg and I. And again, I would also really appreciate it if you take a few minutes to complete the survey at the end of the training. That will really help to inform the future series or meetings in the series. But we are excited about this. I hope this is helpful to everyone, and thanks for joining today.
Hi, good morning, everyone. My name is Dr. Grace Hennessey. I'm the Associate Chief of Addiction Psychiatry for the Office of Addiction Services and Supports, otherwise known as OASAS. Next slide, please. I don't have any financial disclosures to make today, but I do have a couple of office-related disclosures. Right now, there's a fire drill going on outside. I'm sheltering in place instead of going into the hallway like they told me to. But in case someone knocks on my door and says, please, you need to come out, I may have to pause temporarily, and I do apologize for that. Really, of all days to have a fire drill, it was supposed to also be at 9:30. So again, I apologize if I do have to take some kind of break temporarily. The other disclosure is I have an old radiator in my office and it clangs from time to time. You may have just heard it 10 seconds ago, but it may clang and that's just normal for this office. And my last disclosure is I should tell you who I am. So before becoming the Associate Chief Medical Officer of Addiction Psychiatry for OASAS in June of 2020, I worked for many years as a clinician. Primarily, I worked for the VA here in Manhattan, where I ran the outpatient substance use disorder recovery program. I also was the chief of hospital psychiatry, and I was the addiction psychiatry program director, fellowship director, excuse me, for NYU. So I've taken many substance use disorder histories over the years, and I've taught people about it. So I'm hoping that we can impart some knowledge, maybe give you some tips to help you when you're assessing substance use in patients who come and present in mental health clinic settings. My way is by no means the best. It's not the only way. I imagine some of you have some other thoughts. Maybe you'll share them with us about questions you like to ask. And we would certainly be interested in hearing that in the end. Next slide, please. So our learning objectives for today, we're going to understand the relationship between substance use and psychiatric symptoms and disorders, understand interview techniques that can be utilized when taking a substance use history, describe ways to elicit information about commonly used substances such as alcohol, opioids, cocaine, methamphetamine, cannabis, benzodiazepines, and tobacco. Describe 2 methods for organizing a substance use history, understand the general criteria for substance-related disorders, and describe different etiological relationships for substance use and psychiatric symptoms and disorders. Next slide, please. This slide helps demonstrate why integrating mental health and substance use disorder treatment is so important. In 2020, the 2020 National Survey on Drug Use and Health, published by SAMHSA, found that 17 million individuals had a substance use disorder and a mental health disorder diagnosis. And that's the group in the green in the middle. While this number is less than those for substance use disorder alone or mental health disorders alone, it does represent a notable segment of the population who may first seek treatment in mental health clinics such as yours. Therefore, being able to assess substance use in all individuals who present to mental health clinics for treatment can help them receive the best care possible for both disorders. Next slide, please. Here's an example of a substance use history that you may see in a patient's chart. So Ms. K is a 35-year-old female who reports that she's been drinking 6 beers each night for the past few months. She said she started drinking 2 beers per night starting in January of this year, and then increased her use to 6 beers per night over the last 6 months. She has been going to work every day despite her alcohol use. She denied hospital admissions for detoxification from alcohol, and she never drinks and drives. She denied psychiatric problems currently or in the past. She said she does not use other drugs. And in the summary, although 6 beers per night is more than what is recommended for a woman her age, Ms. K does not meet criteria for alcohol use disorder, and she does not appear to have major depression. Now, this is a reasonable history to get from someone, but you have to ask yourself, does this tell the whole history? And as we go through the course of this talk, we'll find that actually adding some key points to the information that you have here will help you have a better understanding of what the true substance use issues for Ms. K and psychiatric disorder issues are for her as well. Next slide, please. Before we get into the components of the interview itself, I just want to give a few words about interviewing techniques. Patients are usually reluctant to report substance use when they come to mental health clinics because of concerns about stigma, both external, that they may be concerned they will experience from others, or internal, their own shame and their own negative self-view because of their substance use. They may not really understand how severe their substance use really is. They use, but they don't maybe have a good understanding of how it's affecting their lives. They may have concerns about discussing potential illegal activity related to substance use, and in a related way, concerns about what information may be shared with others, so such as legal entities, protective services, family, employers, or other treaters. They may have concerns about the effect on the developing therapeutic alliance. So they may be coming to see you because they really need help, but they're concerned if they talk about their cannabis use, you may not be as interested in helping them. And they may also be concerned that their psychiatric or mental health symptoms may not be taken as seriously if you talk about substance use. So the thought would be, oh, this person doesn't really suffer from a psychiatric condition. It's just all their substance use. Next slide, please. So to help patients, we want to really be patient-centered when we meet with them. So you want to be very welcoming, things to say to them, how can I help you today, or what brings you in today? If possible in your office, let them choose where they sit, if that's feasible. I had a colleague once who had patients who, when they let them, would often sit in his chair, so he had to stop doing that. But if you have places where people can sit, let them choose what's most comfortable for them, because they're already going to be anxious, and we want to make them as comfortable as possible. Provide assurances if necessary that information about substance use is protected by law. So I want you to know that any information you give me about substance use is protected by confidentiality laws. Let them know that they don't have to answer questions if they feel uncomfortable. So I often would say things like, there are a number of questions for us to go through, but you don't need to answer if the question makes you feel uncomfortable. Ask as much as possible, ask concise, open-ended questions during the interview. So can you tell me more about your heroin use? And ask questions if you don't understand a term. You say you smoke dabs. Can you tell me what a dab is? I can tell you many years of taking substance use histories. I also did a lot of groups. Patients really like to teach us. They really are excited when they feel they can provide us information that helps us make us better clinicians. So don't be afraid to ask if they use terms about substance use that you really don't understand. Next slide, please. So this slide just lists what are the basic components of a psychiatric evaluation in general. It probably looks familiar to a lot of people, or a psychosocial evaluation. Next slide, please. But we're just going to, thank you. We're just going to focus on certain parts of this today in terms of our substance use history. So the chief complaint, the history of present illness, the substance use history, including the treatment history, and the diagnoses. Next slide, please. So all interviews start with the chief complaint. So we've already welcomed our patient. How can I help you today? And they will likely tell us what they need. So sometimes this chief complaint can be straightforward and focused on themselves in regards to a substance use issue. So they may say, I'm worried about my drinking, or I almost died from a heroin overdose. Sometimes that chief complaint may be externalized or not very clear. My husband is worried about my drinking. I'm not. They say I almost died from a heroin overdose. I didn't. I don't know, my parents made me come here, or something like the courts. And sometimes, and this will probably be true in your clinics, is it may present as something else, but it's really a substance use issue. So I've been depressed for 6 months, or I keep having these panic attacks. So a chief complaint can be all over the place, but it sets the frame for what the interview will be like. Next slide, please. So once you have some kind of understanding of what brought them in to see you, and if it's a substance-related chief complaint, you can start gathering information about the history of the present issues or any illness associated with substance use. So the HPI, as you know, is a systematic and organized way to collect information about recent substance use. And just some general tips, if someone's using several substances, they might say, I drink and I smoke weed and crack. I often like to break it down. So I often will ask people, do you prefer one substance over the others? Or if you can only have one of these substances, which one will it be? Because sometimes people will gravitate towards one substance, and that's usually the one that has the most history and you'll get the most information about, and then you can work on talking about the other ones as well. And for all substances that you ask about, you want to ask how often you're using, how often you're drinking, how often you're smoking, when was your last use, how have you been feeling since you stopped using. Patients do sometimes come to the offices intoxicated. It's not common, but patients will. So you want to be thoughtful of that, but you also want to be thoughtful about withdrawal symptoms. So that's why I would ask them about how you've been feeling since you stopped using. So you have any concern about intoxication or withdrawal symptoms that could lead to significant impairment or death, they need to be addressed right away. Forget your interview. That comes first. If you work in a clinic in a hospital setting, you can take them to the ED. You can, of course, call your supervisor or someone to assist you with all of this, or you may need to call 911 if you're in a clinic or a private setting. Next slide, please. So to think about specific questions you might want to ask about different substances, we'll start with alcohol. And we're going to spend a couple of slides on this because, we do talk a lot about, and we should be talking about, the opioid crisis, and that many people are dying using opioids. It is a serious crisis in this country. Many people still drink alcohol. Alcohol is still a primary substance for many people, and often the first substance that they used. So when you're asking people about alcohol, you want to ask, what kind of alcohol do you like to drink? And you want to review all different types of alcohol, so beer, wine, and spirits. Ask about each, because sometimes those consuming spirits, or people drinking hard alcohol regularly, may not really consider beer worth mentioning. So they may say, yeah, I'm drinking a pint of vodka on Fridays and Saturdays, but they may not mention that they drink 4 or 5 beers on Fridays and Saturdays with the pint of hard alcohol, or that they have 6 or 7 beers Sunday through Thursday. Because again, sometimes when people move on to hard alcohol, they sort of minimize beer, but it's important to understand that as well. And then some people whose primary substances other than alcohol don't really consider beer to be alcohol. They may be smoking crack, they might use a little bit of beer to help offset the effects of it. So they don't really consider it drinking, but it's important to ask though, again, I always highlight beer because a lot of people undervalue it if they have more serious alcohol use or sometimes using other substances. Ask what type of whatever they like to drink. So what type of, a hard alcohol do you like to drink? What kind of wine or what brands do you like to drink? Because you want to understand alcohol content in what people are drinking. And this varies widely between different types of alcohol and also brands within alcohol. And beer is a prime example. I'm going to talk about that in a minute. So the way we think about alcohol content is proof versus alcohol content by volume. They're actually kind of the same thing. They're just multiples of each other. So proof is a measurement of alcohol content, alcohol by volume, or ABV is a measure of alcohol content, and proof is just twice the ABV. So if something is 50% ABV, it's 100 proof. Bacardi 151, I have no idea if it's still on the market. It was when I was a teenager. That's proof. So the 151 in Bacardi 151 rum name is the proof. So Bacardi 151 was 75% alcohol by volume, which is an incredible amount of alcohol. Next slide, please. So once you have an understanding of what someone is drinking, you can actually convert to standard drinks and talk to them about how much alcohol they're actually consuming. So there are standard drink measurements. So 12 ounces of beer, that's 5% alcohol by volume, ABV, is one standard drink. 8 to 9 ounces of malt liquor, that is 7% ABV, 5 ounces of table wine, that is 12% ABV, and 1.5 shots of distilled spirits that are 40% ABV or 80 proof. And these are sort of common. These are sort of the common, when you go to the store or you go to the liquor store, what you buy, these are sort of the common ABVs that you'll find in these different types of alcohol. But things got complicated. It used to be really easy to calculate. So if someone said they were drinking 6 12-ounce cans or bottles of beer in a day, that would be 6 drinks, right? So 6 standard drinks, 12 ounces of beer. If it's Budweiser, it's around 5 ABV. But it's changed a lot over the last 15 to 20 years. So for example, Goose Island, which is a company owned by Anheuser-Busch, makes several different types of beers. All companies make multiple types of beers now. Summer Ale is one of their beers, which fits the standard drink measurement. So it's 5% ABV. They have an India Pale Ale where you're pushing sort of 6%. So if you're drinking 12 ounces of that, you're drinking a little bit more than a standard drink. But then they also have something called Bourbon County Brand Stout, which is a little under 14% ABV. So those are often served in smaller glasses. You'll often get 10 ounces, but you could get 12 or 13 ounces of that in a bar or a restaurant. So if someone's drinking 12 ounces of Bourbon County Brand Stout, they're almost at 3 standard drinks, right? So we're closing in on 15, they're 2 3/4. So that's a big difference. That's very different than drinking one 12-ounce bottle of Budweiser at 5% ABV. So it's important to understand, again, particularly with beer, what exactly that they're drinking. When I was researching this, someone sort of gave this idea about if you don't know your ABV in the alcohol that you're drinking, if you're pretty trashed after 12 ounces, the ABV is definitely too high. Next slide, please. Another thing to ask people about is malt liquor. Malt liquor is an alcoholic beverage with 5% or higher ABV, so it always is above that amount. That's why it's separated out in terms of the standard drink list. It's made from malted barley. There's some common brands that are listed there. So Colt 45 you see is 5.6% ABV. Old English varies. There's different brands, 5% to 8%. King Cobra 6%, and St. Ides is probably the highest at 8%. But malt liquor often comes in 40-ounce bottles. So you're getting a lot more alcohol content by volume when you do drink most malt liquors. So you might have one 40-ounce St. Ides is about 4 to 5 standard drinks if it's a 40-ounce. So you want to be careful there, because again, sometimes we get caught up, and the reason why I put one in parentheses is we hear one and we think that's enough. So people say they drink 1 pint of hard alcohol. Well, 1 pint of hard alcohol is about 7 to 8 standard drinks. So you have to really be careful. And this is why I like to make this point when we're talking to people about alcohol, to really get a good understanding of what they're drinking, because it can have serious effects. If you're drinking higher alcohol by volume content alcohol, it's going to have more detrimental effects on your health than lower content. Next slide, please. So moving on to heroin, specific questions you want to ask about heroin is the route by which it's used. So do you use by snorting, smoking, or injection? You should also ask about skin popping, which I apologize, got left off the slide. So that's when people inject subcutaneously, usually because their veins do not work any longer. A lot of times people quantify it as bags. I was talking to a colleague and she was like, nobody says bags anymore. I'm like, well, when I was working at the VA, people still said bags. People will also talk about grams. So it's usually, if people say they talk about heroin use in terms of grams, it's usually in multiples of tenths of a gram. So like 0.5, so half a gram might be a common thing that people say they use. If people are talking about bags and they say a bundle, that's 10 bags of heroin. Brick, I haven't heard the term brick, but I like to bring it up because I think with the vets, sometimes I saw older vets and they would use these terms, but that's about 5 bundles or 50 bags. The purity of heroin has become so great that really people using bundles is not common anymore. So again, grams may be the way they express it, or they may just say I'm using 1 or 2 bags a day, which again doesn't sound a lot, but because of the purity, it really is more than you might think. Inhalation use is not very common. The slang term for that is chasing the dragon. So what usually is people put an opioid solution or the powder and they heat it on an aluminum foil, and then they suck up the vapor through a tube, or they may put their face close to the aluminum foil. Truthfully, a lot of heroin is lost in the heating process when you do it that way and try to inhale it. So most people don't use it, but some people do. So it's a term worth knowing, again, if someone mentions it while you're taking your substance use history. Next slide, please. You want to ask about other opioids as well, because as we know from the opioid epidemic, a lot of people who moved on to heroin and now fentanyl, really, a lot of them started with the prescription opioids first. So you want to, just a few common names, so hydrocodone, oxycodone, codeine, and morphine. Really, hydrocodone and oxycodone are probably the things that you will hear the most in terms of people having started with pill forms of opioids, because those are the ones that are most commonly prescribed, but codeine and morphine are still out there. So they are something, that people may mention as well. It's hard to have this talk without mentioning fentanyl in a big way. You want to ask about fentanyl. So are you using fentanyl? There was a time where not that long ago, people would be like, yeah, I'm just using heroin. But now I will talk to patients and they'll say, I'm using fentanyl, because they know they're getting fentanyl. Or the person who's selling the drugs to them says, yeah, now this is pure fentanyl. And we know that it's a powerful synthetic opioid. It is similar to morphine, but it's incredibly potent. So it's 50 times more potent than heroin and 100 times more potent than morphine. So it's incredibly dangerous. There's also other analogs. There's carfentanil, which is 100 times more potent than fentanyl. You don't see as much of that. Mostly you see fentanyl, but there is carfentanil out there. Challenge with fentanyl is that you may get that as your opioid when you buy it, but it's also mixed with or substituted for heroin, cocaine, methamphetamine, MDMA. It's pressed into pills and sold as prescription benzodiazepines or stimulants on the streets. So people are like, hey, I got some Xanax. It's not Xanax. It is actually fentanyl. And you can ask patients if they know they're using fentanyl or they suspect that they're using a substance where fentanyl is mixed or substituted in, because they'll get an opioid response, not necessarily a stimulant response. But you do want to check with people about fentanyl. Next slide, please. In terms of cocaine, again, you want to ask about route of administration, to use by sniffing, smoking, or injecting intravenously or skin popping. Sometimes patients are not really able to quantify as much as they use in terms of cocaine, but people are always aware of how much money they spend. And so over time, when I would take histories from people in general, but particularly with cocaine, I kind of shifted to asking people about how much money they would spend. So how much do you spend in a usual day when you're using, in a week or a month? You know, you can ask over periods of time, depending on what kind of answers they give you. They may say amounts. So an eighth ball is an eighth of an ounce of powder cocaine, or about 3.5 grams. Cracks or rocks. You know, they come in different sizes. They can be, you know, different in terms of what people are using. Intravenous use alone of cocaine is not terribly common. It happens, it's not terribly common, but it's often mixed with heroin, and you've probably heard the term speedball. So you do want to ask people too, if they are talking about injecting cocaine, are they mixing it with other substances? And usually it would be heroin. It could also be fentanyl, but usually it's heroin that they're mixing it with when they use the term speedball. Next slide, please. For methamphetamine, a lot of the questions are pretty much the same. So do you use by snorting, smoking, injecting? But also people will insert methamphetamine rectally for use, and you can also swallow pills or powder. So there's a few more questions there that you can ask people about methamphetamine because of the way it works. Methamphetamine is still usually a pill or a powder. Crystal meth resembles glass fragments or shiny blue-white rocks. So if they describe to you what they're using, if they say they're kind of shiny and blue-white, more likely it's crystal meth. Again, similar to cocaine, some patients may not be able to quantify how much they use, but they are aware of how much they spend. So similar questions that you can ask there regarding the use. Goofball is a term I came across earlier in the year. That is simultaneous injection of methamphetamine and heroin. I've not heard anybody use that term. I saw it in the literature. You can also have fentanyl and methamphetamine injected. As far as I know, that does not have a special name. But again, if people think they're buying heroin and they're getting fentanyl and they are injecting methamphetamine with it, again, it may be fentanyl that they're injecting. So goofball, even though they say it's supposed to be heroin, it may actually be fentanyl. Next slide, please. Cannabis, do you smoke cannabis or marijuana? Do you use it other ways? Even though smoking remains the primary means of administration, we know now, because it's so much out there, that there's lots of ways to use it. So when they're smoking, do they use pipes? Do they smoke joints? Do they smoke out of blunts or bongs? So blunts is probably known as a cigar. It's a hollowed out cigar, and it's replaced with cannabis. The nicotine in there is replaced with cannabis, or it can be mixed in and they smoke both. Edibles, brownies, candies, teas, other types of liquid forms of it. Dabs is something that is an incredibly high THC concentrate. Dabs can be anywhere from 70 to up to 90% THC content. There's also equipment that goes along with it. It's heated on a hot surface like a nail. It's not actually any kind of nail. You can do it, but their nails are actually made of ceramic. There's a dab ring that goes along with it that it's inhaled through. There's even special little lighters that you use through it. So if someone says they're dabbing, it's just a very, very high concentrate of THC that they are inhaling through this mechanism. They may vape, so vaporizers, or they may use electronic cigarettes for this purpose, tinctures, so there may be drops under their tongue, or there are other types of sprays. Next slide, please. Benzodiazepines, some people will come to you, and this would probably be very common in the clinic. So benzodiazepines are not illegal substances. They are prescribed. Some people will be prescribed them to treat their disorders. You do want to ask about them in general. So even if someone is prescribed them, you do want to see if they are misusing them. So let's say they say they are using Klonopin, but it's not prescribed. So you want to know, do you use benzodiazepines that you get from someone else? If they are prescribed, do they have more than one prescriber? These days, doctors can check, in something called iStop to see if people are getting prescription medications from multiple prescribers. So I still ask, but I can look it up as well. Do they use one more pharmacy? Again, there's a lot more restrictions on things these days in terms of being able to have multiple pharmacies, multiple prescriptions, multiple prescribers, but you still want to know if they are, getting them from multiple places. If they're purchasing from others, they may not actually know the benzodiazepine or the dose. Sometimes they'll say it's a color, like people be like, oh yeah, I'm buying those like light yellow ones. I actually don't know what the light yellow ones are. I have some colleagues who'll pull out the physician's desk reference and see if they can get a picture, because the generics are usually the same color as the brand name compound. Some people will mention it. In terms of benzodiazepines, if people are prescribed them or misusing them, really alprazolam or Xanax and clonazepam or Klonopin are the most common medications that again are prescribed legitimately, but also used on the street. Sometimes people will talk about a Xanax as sticks or bars or Snicker bars, which is a 2 milligram tablet. And it's actually a long tablet that's scored. It's got 4 lines. It's scored so that it can be broken into 4 equal pieces of 0.5 milligrams. So sometimes people will say, I'm taking 3 bars a day or 3 sticks. So now you know that is equal to, again, each stick 2 milligrams of alprazolam. Abuse of other benzos like Valium, Librium, Ativan, which is also lorazepam, is not terribly common, but you should just ask about other benzos if people know they may be misusing those. But again, it's more commonly Xanax and Klonopin that people will report using. Next slide, please. Tobacco. Do you use tobacco? In what form do you use it? So cigarettes, or do they roll their own? It's important to know health-wise if people are rolling their own, because rolling ones don't have filters. There's other, you want to know about other forms. So smokeless tobacco, chewing tobacco, which is just tobacco leaves that are shredded. Dip, which is tobacco leaves that are fire cured and ground up. And then people put it, as you know, in between their cheek and their gum. Snus, which is tobacco leaves that are pasteurized. You use it in a similar way, and the juice can be swallowed from there. E-cigarettes are vapes, which heats liquid nicotine and other additives, creates a vapor. Or do they use cigars or pipes? Sometimes people don't ask about cigars or pipes, and sort of thinking about our beer issue before. Some people don't think that cigars or pipes is sort of tobacco use, but it really is. So I often will ask about those as well. More specifically, again, in the same way that you do for beer, because people won't recognize them as a major issue. Next slide, please. Okay, so now that we reviewed sort of the major substances that you're going to ask about, you want to just learn more about the consequences of their substance use. So either as you're attaining information about each substance, or after you've gotten this general overview of what they are using, again, you can ask these questions about consequences of substance use, and this will help you determine if someone meets criteria for a substance-related disorder. So what's on the next couple of slides are all the DSM-5 criteria for substance-related disorders. This is true for all the substances, so you can add the substance that you're talking about within the discussion. Things that you want to know about, and these are a bit out of order when you would look at them in the DSM-5, honestly, because when you're making slides, sometimes you got to shuffle things around. So you want to understand about tolerance. So did you need more and more of the substance over time to get the same effect? Withdrawal, what did it feel like when or if you stopped using suddenly? The substance is taken in larger amounts or over longer periods of time than intended. So did you ever try to limit the amount you used, or the amount of time you spent using? How did you do it? Or were you able to limit it, either the amount or the time? Unsuccessful efforts at reducing or stopping down. So have you ever tried to cut down on your use or stop? How did it go? Were you able to? Next slide, please. Other criteria include craving or strong desire to use. So when you're not using, do you crave, fill in the blank, or feel like you really want to use? And craving is different than withdrawal symptoms. So craving is that gotta have it kind of feeling. It's not like gotta have it because I'm sweaty and I'm nauseous, and if I use, I'll feel better. That was on the other slide. That's withdrawal. But craving is that like, just really, really need it. Really gotta have it. We've all had cravings for food at some time. It's just something you really want. So again, it's different than withdrawal. Recurrent use resulting in failure to fulfill major role obligations at work, school, or home. So you can ask a lot of different questions. Have you ever lost a job because of your use? Was your job performance affected by your use? Did your grades when you were in school, or your attendance, or your performance in sports or clubs become affected by your use? Did you stop taking care of your home or obligations such as paying bills because of your use? So a lot of different ways that you can ask about this, but it has to be recurrent. So, if it's one time they skip the bills, it may not, count, but if it's happening every month because they're using the money to pay for substances and not paying their bills, then that's a different story. Next slide, please. Other criteria, so continued use despite having persistent or recurrent social or interpersonal problems caused or worsened by use. So did you lose important relationships because of your use? Do you have legal problems because of your use? Continued use despite physical or psychological problems caused or worsened by use. So someone may say they have asthma. So you mentioned that you have asthma. Did smoking worsen your asthma? And if yes, did you continue to smoke even though you knew your asthma was worse? Or you've been diagnosed with depression. Do you think using heroin affected your depression? If they say yes, and they said it made it worse, did you think that cutting back on heroin would make your depression better? Next slide, please. Excessive amounts of time spent obtaining the substance, using the substance, or recovering from use. So how much time would it take you to get fill in the blank? How long would you use for? So people may go on binges for several days. How long would it take you to get over a period of using? So those were all questions that will satisfy that criteria. Giving up or reducing involvement in important activities. So are there enjoyable things that you used to do that you don't do now or stop doing because of your use? And then recurrent use in situations where it's physically hazard to do so. Do you drive your car or ride a bicycle or operate other heavy machinery when you're using? And if they say yes, particularly to cars or heavy machinery, you might want to ask about, again, that's where a legal question may come up. Sorry, these got a little bit out of order. So usually a follow-up question, if people say they're driving a car, or they've done some kind of hazardous activity while they were intoxicated, you might want to ask about directly then about a legal problem related to that issue. Next slide, please. Okay, so those are all the DSM criteria. We also want to understand people's treatment history. So information about treatment history is really important because you can gain an understanding about what substance use disorder treatment they may have now. And also what they may have had in the past, because that helps you understand what did and didn't work. And if you're giving people recommendations, that can be incredibly useful going forward. So you want to know if they've had detox admissions, how many and where, and how many and where really counts for the next couple as well. Have they ever been in a rehabilitation program, inpatient rehabilitation, in a therapeutic community? So therapeutic communities are sort of, we often would kind of, when I was training, we'd call it kind of the boot camp of substance use disorder treatment. So those are very structured programs where people have certain roles that they play. You have sort of privileges that you gain over time. They are structured. They can be very helpful to some people, not to everyone, but they're something you should ask about. Halfway houses or sober houses, or reintegration types of treatments. Involvement in 12-step or other self-help groups. Some people do, rational recovery is one that comes up. My brain stopped for a second, my apology. There's the classic 12 steps, but there are others as well. So you might want to ask people, do you do other types of self-help groups? Are they involved in other community organizations that help them stay sober? So are they involved in their church? When I worked at the VA, I worked with many, many veterans who did not like 12-step groups, but were incredibly spiritual, and they volunteered at their church, or they were involved in a particular church group, and they found that incredibly helpful for keeping them sober. Do you go to a local community center, a senior organization, a senior center? So there's a lot of different ways that people can stay sober and be involved in their community other than 12-step groups. Have they ever had psychotherapy, individual or group treatment for substance use disorders, intensive outpatient programs, and medications are good to ask about as well. So for alcohol, the 3 sort of FDA approved medications for alcohol use disorder, naltrexone, disulfiram or Antabuse, which makes you sick, and acamprosate, all can be medications that people may have been prescribed. Opioids, methadone. If they say they've been on methadone, you want to ask about what clinic they've been connected to, because methadone can only be dispensed by a clinic for the treatment of opioid use disorder. Buprenorphine, naltrexone is also used to treat opioid use disorder, and what kind of treatments they've had for tobaccos, patch gum, lozenges. I forgot to include varenicline, so other medications, or do they use e-cigarettes to help them quit? Next slide, please. Okay, so here we are. So you've gotten all your information. You've got their substances, what substance they're using, the treatment that they've had. Now you want to organize it. So I often think there's two ways you can organize the information that you've got. One is by substance. This is the way I prefer. I often say I'm a splitter and not a lumper. So I always like to, when I write up my reports, I like to do it by substance. So here's one example. So for alcohol, first tried alcohol at age 16 with friends after school, did not drink again until graduation when she became intoxicated for the first time, continued to drink to intoxication every weekend and 1 to 2 weeknights for the next 2 years. By age 20, she found that she was tolerant to the effects of alcohol. So it had increased from 2 glasses of wine at age 18 to a whole bottle by age 20, had craving when not drinking, drove while intoxicated, and lost girlfriend because of alcohol and cocaine use. In terms of the cocaine history, first tried powder cocaine at age 19 when intoxicated, found that cocaine helped offset feelings of alcohol intoxication, and she could drink more and more for longer periods. By age 20, she was snorting $40 worth of cocaine per day, an increase from $20 per day the year before. Girlfriend broke up with her because of her alcohol and cocaine use, and she lost a job because she missed work on 3 occasions after using cocaine and alcohol. She also drove after using cocaine and alcohol several times. So sometimes, again, even though it's divided up by substance, you might weave in the other substance that's being used, particularly if it's, we talked about alcohol first, so you can mention the alcohol and the cocaine history. So that's one way to organize it, is by substance. And then next slide, please. Oh, can we go back for a sec? Chronologically, thank you. So the other way you can do this is kind of breaking down the history into discrete periods of time and getting information about all substances used in the time frame. My mentor, who taught me how to take substance use disorder histories, loved this method. I went the other way, but she was always really great about being able to do these types of write-ups. And this may work for you as well. So from age 16 to 20, first drank alcohol after school with friends at age 16, did not drink again until high school graduation, became intoxicated at graduation and continued to drink to intoxication every weekend and 1 to 2 weeknights for the next 2 years. Tried powder cocaine when drunk at age 19 and found that using cocaine helped offset feelings of intoxication and allowed for continued alcohol use. By age 20, needed to drink a whole bottle of wine to become intoxicated when 2 glasses of wine had been enough at age 18. Was snorting $20 worth of cocaine twice a week at age 18, but by age 20, but within a year, at age 18, but by age 20, was snorting $40 3 times per week, reports losing girlfriend secondary to use, being asked to leave home because of use, craving both substances when not using, trying to cut back on both substances several times, unable to do so, spends most weekends, intoxicated on both substances, is driven under the influence, was fired from 2 jobs because she did not show up when she was using or recovering. So again, either way works. You kind of figure out your own way to document people's history. I think either is fine. Again, I just like to split things up by substance. So that was always my way, but you can see this works equally as well. Next slide, please. But did we do things backwards? Sorry, let me do the one after that. Okay. So now I'm going to go over again, sort of putting together somebody's whole story and just kind of also show you areas where you can, in documentation, where you can help really be clear about what your diagnosis says. So this is a story about Mr. R. His cocaine, first tried powder cocaine at age 20. He said he used powder cocaine mostly at parties, but escalated his use to daily or near daily soon after he tried crack at age 31. He said during the last 9 years, he has had few periods of abstinence. He reported use of cocaine in larger amounts and for longer periods of time than intended, craving for cocaine, tolerance to the effects of cocaine, significant amounts of time using or recovering from the effects of cocaine. use of cocaine in situations where it was hazardous to do so, so drove right after smoking cocaine several times, and multiple unsuccessful attempts to reduce or stop smoking crack cocaine. He said his wife divorced him because of his crack use. He denied withdrawal, use of cocaine despite knowledge of cocaine-related medical problems, reducing giving up important activities because of cocaine use, loss of work because of cocaine use. He denied IV use, and his longest period of sobriety was from cocaine is 27 days, which is current. Next slide, please. So again, his substances, so he denied use of other substances, including alcohol, opiates, benzodiazepines, barbiturates, hallucinogens, stimulants, marijuana, and tobacco. And for his treatment, he was admitted 3 times for inpatient residential rehabilitation. This is his first outpatient treatment. He said he is not interested in 12-step meetings, but is considering joining a support group for individuals in recovery run at his local church. So this is a very simple history. They're not all this simple. Sometimes there's lots of substances and other things going on, but this just kind of gives you an example of sort of putting together this entire substance use history. And what I like to do when I write it up, next slide, please, is to sort of put all kind of the pertinent positives together, so to speak, or the pertinent information that helps me diagnose whether or not this is a substance-related disorder and what is the severity. So I just highlighted again, kind of that middle section, which sort of goes over the positives. So again, using cocaine in larger amounts, craving, needing more over time, significant amounts of time trying to buy and smoke cocaine, using cocaine where it's hazardous, multiple unsuccessful attempts to reduce or stop, and that he lost an important relationship, that his wife divorced him. Next slide, please. I also like to write down the pertinent negatives or the things that someone denies to me when they are giving me histories, just because, again, it helps make the diagnosis and it helps remind me that I did review everything to make sure I got the diagnosis right. So he denied withdrawal, use of cocaine, despite knowledge of medical and psych problems, reducing giving up activities, and loss of work. And also, I didn't highlight it, but I also will ask about the other substance, the ways of using substances. So he reported smoking and powder use. So I will always ask the question about IV use. But again, in sort of trying to think about the diagnosis, I like to make sure I've gotten everything sort of down. So I give a proper diagnosis, because it's really important that you don't just throw labels on people, right? We don't like to label people, and we should always be thoughtful about diagnosis that we give completely in all our work. But again, with substance use disorders, it's really important that you get it right. These diagnoses stick, and they go along with people. So you want to make sure that you get it correct as much as you can. Next slide, please. So for this gentleman, Mr. R, he would meet criteria for cocaine use disorder severe, because he actually had 7 symptoms that were positive. So mild, so when you're doing your diagnoses, you want to do mild, moderate, or severe. So mild is 2 or 3 symptoms, moderate is 4 or 5 symptoms, and severe is 6 or more symptoms. This is true for all substance use disorder diagnoses. But again, so for him, he would be severe. You want to specify if he's in early remission. He was not. He's only been abstinent for 27 days. So early remission means at least 3, but less than 12 months without meeting criteria for the disorder. Craving is not included in that, because craving can go on for a long time, even when people are sober for many years. Sustained remission means at least 12 months without meeting criteria for the disorder. Again, craving not included. Are they on maintenance therapy? That would only be true for opioid and tobacco use disorder per the DSM, so that doesn't fit with our Mr. R. Or are they in a controlled environment? So did they maintain all that abstinence because they are in a correctional facility or a locked long-term inpatient unit? So those are distinctions you want to make. I think the most important thing is to get the mild, moderate, severe, and really remission, because I've seen charts where someone's in recovery for 5 or 6 years and it still just says cocaine use disorder severe. Really, at that point, they're in remission. It's important to include that. Next slide, please. Okay, so now we're going to go back to the beginning. We're in the home stretch, and we're going to revisit that history that we did before. So this is Miss K again that we started with, And what I did was I just added some extra history. So hopefully you can see now from what we've talked about, by getting a little bit more information, you can really open up this history and get a better diagnosis. So I won't reread the first part because we went over that before, but on further questioning about her beer use, you found out she was initially drinking 12 ounces of Budweiser. So 2 times the 12-ounce beers is 2 standard drinks each night, but now she's drinking 6 12-ounce bottles of a craft beer that she thinks is 10% alcohol by volume. So again, it's double the ABV. So 1 standard drink is 5% ABV. So 1 10% ABV beer is 2 standard drinks per night times 6 per night, which is 12 standard drinks per night. So very different now, right? Than just, oh, she's drinking a couple of beers a night. And she needs to drink that much to achieve the same effect. So you can see that progression, the tolerance that's there for her. She said she's been going to work every day despite her alcohol use. But when asked about work performance, she said she has received 3 reprimands at work for tardiness she attributes to hangovers. So again, opening up that history. No hospitals, but was in the ED last year when she fell and sprained her wrist. She said that she has had several joint injuries, apologies for the typo, and bruises after she fell when intoxicated. She is aware that she fell because she was intoxicated, but it did not make her reconsider her alcohol use. Next slide, please. Ms. K said she never drinks and drives, which she said initially now because she had 2 DUIs in the 1990s and she fears she will lose her license if she drinks and drives again. I'm going to skip down. So she's denying health problems, but when you review her psychiatric symptoms, she reports symptoms consistent with major depression, such as low mood, decreased appetite with weight loss, poor concentration, fatigue, hopelessness, and difficulty sleeping more days than not for the last 2 years, which was prior to the onset of her alcohol use. No suicidal ideation. And again, I always want to ask about other substances. And the first history was just alcohol at its face value. She said she does not use other drugs, but when different classes of substances were reviewed, she said she took Xanax from a friend for about 4 times in the past month to help with hangovers. So another piece of the history. So now the assessment is different. So in this assessment, she does meet criteria for alcohol use disorder moderate. Can I have the next slide, please? And the other piece is now we have a piece about depression. So now she also meets criteria for major depression. Those are all the criteria for major depression. And the important piece of this is that those symptoms started prior to the onset of alcohol use. So when you're taking a history, you want to try to suss those things out regarding when the symptoms started. So again, going to the summary, she meets criteria for alcohol use disorder moderate. She also meets criteria for major depression from this brief interview. And due to time constraints, we couldn't complete the whole interview, but she's going to come back in a week to complete the evaluation. But you got this history, so you have a lot of information here already about, again, an alcohol use disorder, moderate, and a major depression that is independent of the alcohol use disorder. And the last slide, I just want to finish up with a few thoughts since we are talking about integrated treatment. And we just presented that case where there was a depression and an alcohol use disorder. And when you interview people and you get this information, what are these etiological relationships between substance use, psychiatric symptoms, and psychiatric disorders? Sometimes it's incredibly clear that the substance use causes the psychiatric symptom or disorder. So in this case, we call the substance use primary, the psychiatric symptoms or disorder are secondary. And so someone may say something like this: I never had a manic episode until I tried meth when I was 25. Once I stopped using when I was 30, I never had a manic episode. So this is really kind of painfully clear that this is a case where there was no manic episode. They tried meth, they had a manic episode. Once they stopped meth, never again. Fairly cut and dried, fairly straightforward. The other is the opposite, where the psychiatric symptoms or disorders lead to substance use. So again, in this case, the psychiatric symptoms or disorders are primary and the substance use is secondary. So I had my first panic attack at age 17. And when I started drinking alcohol at 18, panic attack stopped. So again, first, very clear again when you can see this and how they relate. Unfortunately, a lot of times when we take histories, we get the third story, which is when the psychiatric symptoms and the substance use occur around the same time. And there's no really clear-cut answer. So someone may say, I had been using heroin for a few weeks when my parents separated when I was 17 years old, and I just felt sad all the time and I couldn't eat or sleep. So again, that's not enough symptoms for depression, but it's indicative perhaps of a depression, and you really just don't know which came first. And I can tell you, and you probably know this from your own experience, many times we get story number 3, where it's really tough to tease out. You want to take a good history of both at that point, but many times you may not be able to have a clear sense of which started first. And on that, next slide, please. I want to thank you all for coming today, and thank you for your attention. I really do hope you picked up maybe some pointers today, or if you're already taking really good substance use histories, I just confirmed some of the stuff that you are already doing, and you're on a good track with that. That is me, at grace.hennessey@oasas.ny.gov. And again, I really thank you for your time today.
Excellent. Thank you, Dr. Hennessey. My name is Boris Vilgorin, and I'm with the MCTAC and the team that put this presentation and the series together. And so again, I just want to remind folks that please feel free to chat in any questions you might have. Also, feel free to raise your hand, if you would like to, and just talk instead of just chatting in the question, and we'll be happy to unmute you. You'll be able to unmute yourself. So just wanted to make sure and also check with my colleague Yvette if she has seen any questions come through.
Not yet. I think we're still waiting for folks to chat those questions in.
Okay. And while we do, I actually, want to ask Dr. Hennessey a question. Early in your presentation, you talked about making sure mentioning that if an individual doesn't feel comfortable answering or talking about particular areas, that they should feel, comfortable not answering at the time. And so I suspect, and especially with the presentation, kind of how we had first version, meaning, what happened, and then later kind of more information became available. I suspect, and again, you mentioned this as well, that people sometimes don't feel comfortable because they might think there might be legal issues or other issues that come up if they disclose their use. I suspect that sometimes it takes multiple sessions before somebody, one, discloses more, or before you really get a full picture. And it doesn't necessarily all happens within the first session or the first 3 sessions even, and sometimes we are led to believe that somehow biopsychosocial in 3 sessions will obtain all the information you need. So maybe you can talk a little bit about timing of it and realistic expectations.
Sure. No, thanks for the question, Boris. And you raise a really good point. I mean, obviously, when you're doing a presentation, everything's idealized, and you can do all of this, magically in 45 minutes that your clinic gives you for new evals. So I think it's an excellent point. We probably won't get to everything necessarily in the first. And sometimes what I do, and it kind of goes back to that point of on the slide, sort of asking people which substance do they prefer. If you could only have one substance, which would it be? Because if you don't have enough time, you may want to hone in on what they think is the biggest issue, and then just kind of go there and get as much of that history as well. And then, say that, we'll ask other questions, another time. So, but if someone says to you, yeah, well, you ask about her, I don't want to talk about that, okay, you just kind of let it go, and so, well, sometimes I'll say to people, is there any reason why you don't want to talk about it? No. And then I just move on. So, a couple of sessions later, maybe you have a little bit more of a rapport. Maybe they get a sense of you that you're not going to go running to the authorities or tell everybody, about their use. And they may let you know a little bit more, yeah, I've used heroin. How often do you use it? I don't want to talk about it. So you just let it go, and you just kind of, pick it up sort of here and there. It's always okay to ask people again, but you want to be respectful, of their boundaries. If people don't want to answer questions, you just don't push. Truthfully, you can take the best history ever, And this probably happened to everybody on the call, and then you find out, 6 months later that, oh, by the way, been using cocaine this whole time. Yeah, we've been working on my alcohol problem, but I've also been using cocaine. And, sometimes I had patients who didn't tell me actually for years about some kind of substance use, which, it happens, and you ask at the first visit and maybe you check in every so often. So you're using any substances? No. And it may not have anything to do but with you and your relationship. It's really just a situation where people are just not comfortable about it, about bringing it up, or, yeah, you were going to mention it, but time kind of got away from you. So I think it's important, that you keep asking people about substances, but they still may not tell you. And I think the important thing is, if one day they do reveal something, you remain calm. You don't go, what? Not that anybody would do that. Or you're not like, you never told me, which is a natural human response, especially if someone is not getting better. You're working with them, you're doing therapy. In my case as a psychiatrist, I'm prescribing medications, we're adjusting medications, they're going to groups, they're not getting better, and then they may say, okay, well, actually, I haven't been taking the meds, I've been using substance A the whole time. And the immediate thing is to be like, what? I probably have done it in my time, I'm not going to lie. I'm an honest psychiatrist, I'm a human being as well. We're people in the room. So it's just really important that you kind of remain calm when people, finally do tell you. And I think when people do finally tell you, it's a great sign of your relationship, that at some point they said, okay, you can, now I can bring this forward. And then they're finally honest with you, and then you just move forward. And I think that answered your question, Boris, if I didn't quite get it.
Yeah, no, definitely. No, I appreciate the honesty, and because I know, speaking to clinic staff, sometimes there's that pressure to get everything up front, to complete the form, if you will. And sometimes the pressure, like if it's on the 10th session, you find out that somebody been using heroin, that somehow you're in trouble because you should have known that in the first session. Or sometimes, unfortunately, you find out because somebody did have an overdose or had some sort of an ED visit, and it wasn't even them disclosing it, but somehow, they had to because of a hospital or whatever it might be. And I know sometimes, clinicians especially feel pressured or feel that they did something wrong.
Sure. Yeah.
Yeah. So no, I appreciate your comments.
Sure. No, and I think it's a great point. And I've also had that happen too. You find out something, is not going well because people overdose, or just thinking generally in terms of mental health. Maybe someone makes a suicide attempt, where they've told you over and over again, they're not suicidal. So I think it's really an excellent point. And, I think you just do the best you can, and you get as much information as you can in the interview, but always you have to remember there's a person in the room, and that you have to respect, where they're at. Patients won't usually go where they don't want to go. So you can't take them where they don't want to go, but you want to be conscious and watch the signs. And if they seem uncomfortable talking about certain issues, you may want to back off too, and they're like, yeah, well, you start, well, and they're answering your questions in a way, and they're kind of antsy, and, you might want to back off and say, let's move on to other questions. We'll come back to this. Having worked at the VA, lots of trauma, lots of PTSD. So, again, as a general idea too, you just want to keep people's body language in mind, or their comfort about it, again, so in sort of a parallel process, people don't always like to talk about their trauma at their first visit, and you don't want to push on those types of things either. So again, they're sort of similar in that way, that people will tell you stuff, but don't push. And you may find out the 10th, the 20th, the 2 years later visit.
Yep, definitely. Thank you. We did get a comment in the chat that somebody would like to share this training with their clinic staff. I think that's a great idea.
Oh, great.
I'd encourage everybody to do it. Again, just as a reminder, we are recording this, and we'll make it available. So folks could definitely, when they get the link to this, please feel free to share it with your clinic staff or others within your organization that you think would be helpful. So thank you for that comment. Again, any other questions or comments from our participants, from our audience today? All I don't see any other comments. I do want to again remind folks that we're, still looking for case submissions and encourage people to submit cases for, we have 5 more that we schedule presentations, and really would love to work with anybody who's interested. We also have a survey link that was put into the chat to give us additional feedback about how we can continuously improve these presentations and these discussions. So really would look forward to your feedback as well. And I also want to invite any of our state partners or city partners or CPI, if there's any other additional words or comments you would like to make before we close off today's session. Okay. Since I'm not hearing anything or seeing in the chat, again, Dr. Hennessey, thank you so much for a great presentation. Really appreciate it. And thank you everybody for joining us for today's presentation. And we'll look forward to our next month webinar. Thank you, everybody.
Hi, everybody. Thanks again for coming.
Take care, everybody.